Yes, we can.
Oh, thank you. Hoping that's a yes, and I appreciate that. Also turning on my video and hoping that you can see me. So, hello. It's an absolute honor to be here. Thank you so much. Happy Fall Prevention Awareness Week for everybody who is celebrating and partaking and hoping and helping to make our older Americans safe out there with great programming. What I'm going to do today is talk a little bit about digital fall programming, so virtual solutions that we can engage our older adults with so that we can help prevent falls and also monitor or detect falls. There's a lot out there, but I am Matthew Smith. I am a professor at the Texas A&M School of Public Health. I wear a few different hats here at A&M in terms of research entities and driving different research and analytics labs. And what I'm going to talk a little bit about today is some of our funded projects and larger national initiatives, just to give a bit of a heads up, but I certainly welcome all kinds of communication. Please, I'll try my best to monitor the chat. But in addition, so much of the work that I do is in terms of evidence-based programs for older adults, not just falls prevention, but also in terms of nutrition. So really appreciated the last talk, as well as physical activity, as well as chronic disease management, social engagement, etc. So falls being extremely near and dear to my heart, something I've been working on for about 2 decades now. Always must lead with a disclaimer that the views and things that I share are mine and not necessarily representing others. So thank you for understanding that. A high level overview of what it is that I will be discussing. First, talking just a little bit about digital solutions to fall prevention and falls detection. There have been a lot of advancements, and we're just going to highlight these. I could spend the entire hour or more talking about these. If you have questions, we can always go into those, but there are so many different types of solutions out there, even some that we've heard about today from our previous speakers, Laren and Jennifer. In addition to that, I will talk a little bit about evidence-based fall prevention programs and the benefits of us translating them into virtual formats. And then I'll focus on the National Institutes of Health funded study where we translated the A Matter of Balance program and the Otago Exercise Program into a digital platform, and we tested it in a non-randomized trial to understand a bit about its engagement and how it works, and its benefits for older adults. And I'll also then move on to some considerations we all can have when thinking about selecting or integrating technology into our collection of fall prevention activities in our communities and our organizations. And then I will give a very high level teaser to a national initiative that I have the fortune of being a part of, and that is the Administration for Community Living, doing the Innovation Lab for Falls Prevention. We are attempting to rethink a bit of fall prevention and think about how it is that we can reach more individuals with things that work. And if I speak fast enough, we will have time for question and answer. So let's see how fast I can truly talk. Well, the great news is I'm hoping almost everybody here has heard this today and knows some of this, but falls are a pretty big problem. We certainly know that about 25% of older adults will fall each and every single year. And if you fall once, you're more likely to fall multiple times. And a lot of those end up in injury. Unfortunately, that means that our older adults have negative consequences, whether it be because they need to be hospitalized, maybe they become immobile, maybe they lose their independence, or maybe even die. And we know that those consequences are expensive, not only to that individual, their family, society, all of the things. And it's estimated that over 100 billion with a B, $1 billion will be spent in fall-related medicines and treatments by 2030, which is not very far off. So this number continues and continues to grow, and we certainly need to do something about it. I also don't need to tell this group that falls are complicated. This is one of the things, and this are some of the things that we've been talking about today. I go back to nutrition and physical activity in the home environment and medications, sleep, social isolation, cognition. All of these things can be risk factors for falls, and they can all contribute to falls. But we also know that once a fall occurs, all of these things are impacted. So there's that upstream, downstream issue of what is the fall? Is that the cause of the problem? Is that a symptom of a different problem? Is that the outcome of interest? There are so many things happening. And in our communities, we have various, programs and supports that require different partnerships and collaborations supported by policies. We really need to look at all of this in so many different ways. In a community to prevent falls, we need multiple levels of fall prevention and intervention. And with that said, we need changes in clinical care. We also need to offer things in community-based settings, including in-home settings. And we also need to introduce and enforce policies to make sure that we can support these mechanisms and that our older adults can get access to services and programs that they need. Among these, of course, are also digital solutions. So, in this suite of efforts, in this complication, we certainly want to try to identify all of those things that we can do to round out our collection, our constellation of fall prevention activities. So, I'm going to talk a little bit about digital solutions. And these are those emerging technologies specific to falls. Now, this should come of no surprise because we are inundated with new products, new technologies, and there have been a very large expansion of technologies that have been released that can reduce fall-related risk and also detect falls. And this is fantastic in many different ways because the technologies are advancing in such a way that they're becoming more and more affordable. And when they become more affordable, they become more accessible. They also are becoming very sophisticated and they're having better and better accuracy with what they can identify, what they can detect, the way that they can store data, the way they transmit data, and also even being able to identify and tailor what an individual needs so that they can benefit. With that said, this can make fall prevention efforts pretty cost effective. By getting a technology, we alleviate the human burden in some ways, and we complement their ability to see larger caseloads, and also be able to collect data more seamlessly. It really does alleviate a lot of the burdens with traditional fall prevention efforts. And the great news is that technologies are being used by older adults, but they're really benefiting the older adult as well as their caregivers and their healthcare teams. So everybody's able to share information, see progress, identify risk. If something happens, they're notified quickly. And these are some of the benefits of why technologies are so beneficial for fall prevention and detection is because they can educate older adults. They can make them aware of risk factors. They can make them aware of things that they can integrate into their daily lives to be able to prevent falls or reduce related risk. In addition, many of the technologies, like the ones spoken about today, are in terms of risk identification. So we can identify various risk factors. We can do this in real time. Those can be communicated to the older adult and/or their healthcare team very quickly. And we can communicate, oftentimes reinforcing one another, but also sharing data with our teams, with our caregivers, with individuals, and ourselves over time to monitor our progress and identify these things for intervention support. Some of the technology is extremely useful when it comes down to tailored interventions and saying that just because you have a technology doesn't mean you use it the exact same way. We can actually start to use these technologies for the benefit of the older adult, meeting them where they are, giving tailored and adaptable programming, making sure that it's personally tailored to make sure that the individual is met where they are and can be progressed over time in a safe, hopeful manner. Of course, if something were to arise while using these types of technologies, the communication is advancing. There is faster emergency response time, and we know that. But ultimately, what it comes down to is technologies give a sense of security. They can alleviate some of the falls, but they can also give older adults a much greater sense of safety, of support, of independence. And it gives a lot of the others, the caregivers and the healthcare teams, that same sense of security and confidence that their loved one is living independently and can be communicative. And when we think about these different types of technological solutions, there are many. And I always love this picture at the top hand right with the gentleman in VR. But there are wearables. And those wearables, those pendants, we know, we see the smart watches, we see the pendants around the neck. These are great because they have GIS or accelerometers or gyroscopes. They have different technologies that can look at acceleration or the movement of an individual, the change in position quickly. These are great for falls detection, but also because of the geospatial or the geo-tracking GIS systems, they can also identify where these things occur and where individuals go. It can also be used, of course, in physical activity programs and other types of interventions where we can be more physically active, track our movements, track how fast our pace, etc. Lots of technologies in terms of wearables. When we think about the shoes and the orthotics, I don't know if you've ever seen these, but these can actually modify gait imbalances, sway, time spent on one foot, all these different types of efforts where we can identify an older adult's function and potential changes in function, not just a fall, but progression over time to start to see if there are gait shifts or if there are needs for other types of corrections, other types of interventions. I'm sure everybody's seen some of the exoskeletons, also called power clothing or soft exosuits. These are basically things that you can wear that alleviates the joint strain and can actually power the joints to do activities more effortlessly. Um, there's a lot of these, a lot of them created originally for military purposes, of course, adapted to older adults. There's just so much out there. Other studies that we've done, of course, are in terms of those smart watches, but also in terms of these ambient systems. So trying to look at motion sensors or even acoustic or sound sensors so that we can identify if a fall were to happen or what in the home is occurring so that we can identify the circumstances around the fall or whether or not an older adult needs assistance and maybe can't get to a communication device. Additionally, pressured flooring. We know that there's pressure sensors that we can do in testing situations, but also in smart homes. So there's a lot that's happening, and those, of course, can identify a fall, can identify those gait imbalances or other types of things, but they can also send automated notifications to individuals who need them. And then the other category is really in terms of the risk assessment and training. And here is where I will focus more on today, talking about virtual education, whether that virtual education, that virtual intervention is either synchronous, meaning groups of people are doing it together, maybe by Zoom or by Teams, some other kind of video conference, or if it's asynchronous, go at your own pace, engage as much as you want. That's what we'll be focusing on today. And then we know the virtual reality and the Xer games, these, simulations that can occur and, experiential type interventions, making things gamified, making things a little more fun. So there's just a lot out there, and we could talk about this all day, but really what I want to focus on is a bit of these evidence-based fall prevention programs. These are programs that I am very, very involved with still to this day and have been for a very long time. And that's because they are available, they are supported by our government in terms of the Administration for Community Living, but also Title III-D dollars, etc., but also have a very long history of effectiveness. And for those of you who know, and I know there have been others of these fall prevention programs raised today and mentioned today, I heard Tai Chi earlier. I heard a matter of balance earlier. I heard the Steady Toolkit, Otago Exercise Program, Bingo Size, which I think was started in Kentucky, if I'm right. But there are so many of these programs, and each of these were created for their own purpose for different sectors or different groups of the older adult population, typically based on functionality. And what I like about this graphic that I've adapted from Dr. Jane Mahoney out of Wisconsin is that it shows where at the bottom, when we think about general, older adults and their general level of risk, you can see that at the bottom of this pyramid, that most older adults really can engage in some traditional forms of exercise. We know that they can, there's gardening, there's strength training, there's all kinds of, pickleball and other types of things that can happen. But as we start going up in the pyramid, we see that the risk for falls or those risk factors are increased. Well, that is actually a smaller and smaller proportion of the aging population, but it certainly is considerable, millions of individuals. And so we can see as you go up from traditional exercise, you can see things like Tai Chi being something that is very functional, stepping on, a matter of balance. And then we have more of those one-on-one therapies, which would be like the Otago Exercise Program or even the Capable Program. But there are so many of these different programs, and so many of them meet the needs of a diverse older adult group in a community. So more than one of these might be needed to truly meet the need. Now, the great news is that these evidence-based programs are available, and there are a lot of different places all across the country. Most of them are in small group format, and there has been a huge amount of evidence and literature to show how effective they are. Naturally, many of these are focused on reducing the fear of falling. They're looking at functional mobility, so those physical functioning, strength, balance, flexibility, endurance, but also the efficacy to not only prevent falls, but manage falls if they were to occur. Lots of evidence about these programs and tried and true success. And they're delivered in so many different settings across the aging network. And those are residential facilities and healthcare, healthcare organizations, faith-based organizations, senior centers, area agencies on aging, uh, in homes. I mean, there are so many different places, and that's how, by design, they can be in many of these different places. And they've been supported since 2003 by the Administration for Community Living through grants. And Title 3D dollars typically reimburse these types of interventions, but there's so many others that aren't supported by the ACL grants that are not being delivered by Title 3 or with Title 3D reimbursement and supported by other financial resources. But not only are they in small group settings or small group formats, they're also delivered in many different ways. I talked about some of the virtual delivery or telephonic delivery. These can be done synchronously, where groups of people will join in virtual spaces and take these programs together. But the thing about it is, you can see from this map, which might be a little small, where so many of these programs are and whether they're falls, whether they're disease management, whether there's a combination of both because communities adopt many of these. You can see that millions and millions of older Americans have engaged in these evidence-based programs, but there are millions and millions more who need it and don't have access. So what we're focused on is attempting to translate effective evidence-based programs into virtual delivery modalities so that we can maintain those elements of success, those core components, those essential elements, deliver them safely, and then, of course, hopefully get those same improvements. And that is the example that I would like to focus on now. This is a self-guided digital translation of A Matter of Balance and the Otago Exercise Program, funded by the National Institutes of Health. I always want to give credit to this amazing team who came together from all across the country, including representatives from A Matter of Balance and Maine Health, to create this solution and, of course, test it in real world settings. So again, this was a Small Business Innovations Research, SBIR, funding mechanism from the National Institutes on Aging. Now, I'm going to guess that many of you are familiar with these two programs. One of them being A Matter of Balance, This is the most widely available evidence-based program here in the US. It has been around for a very long time. This is typically a small group intervention where it is about 8 to 12 older adults who get into the same location. Sometimes it's once a week for about 2 hours, 8 weeks consecutively, or sometimes it's two times a week for about 2 hours over a 4 week period. But either way, this is facilitated by trained lay leaders, and it is typically, again, all across the aging network. So many different settings. The evidence of this program is very robust. I've been very proud to contribute to some of this literature because it does reduce the fear of falling. It has been shown to alleviate activity restrictions and even self-reported falls. And there have been dramatic improvements in physical functional mobility more objectively, physical activity, as well as mental health. So lots of benefits, well documented. Similarly, we adapted or adopted the Otago Exercise Program, and this actually came back in the earlier 2000s from New Zealand. One of our CDC grants brought this to the US and translated it for use. So love the Otago program. This is typically an in-home, one-on-one fall prevention program for frailer older adults, those who are a bit more homebound, maybe have more mobility issues, maybe have a more frequent falling profile. And what this is a coordinated 17 different exercises focused on strength and balance that progressively get more difficult with the guidance of a physical therapist, occupational therapist, or others based on the performance and the progressed benefits. So, with that said, naturally, this is an effective program. There's been lots of effectiveness that has been documented here in terms of reduced falls objectively, as well as decreased self-reported fall-related risks, and also objective fall-related risk and physical functioning and mobility, functional assessments. So a lot of great things from these two programs. So why not get them into the hands of the people who need them? So what we aimed to do and what we set out to do was to conduct a national, a non-randomized pragmatic clinical trial in the state of California. This was limited to California. And really what we were attempting to do was try to see how much older adults would use a platform like this. And if they did use it, of course, what was the effectiveness? And this was self-guided translation, so working independently, not with a leader like typically offered, of A Matter of Balance and Otago merged together into one platform. The platform itself was a downloadable app that the older adult could download onto a computer, a tablet, smartphone, all of the above, and also an administrative app. And that was so that somebody, a care recipient, a study team member, a healthcare team, could go ahead and observe and integrate or interact with them, monitor their progress, but also see certain elements of their progression and what they've been accomplishing. So with that, this was avatar guided exercises from the Otago Exercise Program, as well as integrating self-guided educational content from the A Matter of Balance program. So this platform allowed all of the individuals to take the classes, so interact with the sessions, but also be guided with their avatar to perform daily exercise routines and engage in those physical activities that are recommended, and also complete surveys and take different assessments. So with that, it was recommended that the individuals engaged in the platform and did the A Matter of Balance educational content at their own pace, at their own leisure, at their own speed. But then in addition to that, they were able to advance through the Otago exercises, which were at 4 different levels of difficulty, so they could progress over time as they got stronger, as they got more balance, and they could progress those over time. The recommendation was that they would do this 3 times a week, and that they would also engage in a walking program 2 times a week. So these were the recommendations. Do as much education as you want, do as many of these exercises as you want, but try to do so about 3 times a week and also do some walking on the side. The web app, of course, was for administration and monitoring, not something I'll focus on, but certainly these are great tailorability to be able to see if somebody's not engaging. Should we give them text messages? Should we give them other alerts that maybe they should engage? Hey, did you forget this week? Give them reinforcement and congratulate them for doing a job well done, but also be able to see how are they progressing and do they need additional supports, and even assign them more tasks, because some people got into this platform and just did everything all at once and just wanted more, and we could keep opening and offering more and more to them. So a little bit about what the platform looks like. Naturally, you can see there are many different screens and different types of activities. At the top here on the uh, left-hand side, you can see that these are some of the different assessments that could be done. We see these asking different types of questions. We also see that there's some interaction that can be done in terms of conversations or more of scenario play. As you go down to that bottom left-hand side, you can see that everyone had their own dashboard, and you could see the different types of recommendations of activities and education that they would have. It would show you and check off if they did those things. It would also give you demonstrations and show you how to do them and give you as much instruction as possible before you started, which is on that bottom right-hand side, where you can actually do this and your avatar will watch you and do this with you so that you can record the reps, you can record the time, and you can track your own progress. So really fun and innovative system. And so what did we do? Our approach here was we used in the Los Angeles area in California, we used community partners to identify individuals who were 55 and older, who were community dwelling and not living in residential communities. With that said, there were many different ways because evidence-based programs were out there already. There was a lot of recruitment from those types of programs, from those types of organizations that already offer those types of programs, from existing client lists from all of the different partners, to also going and doing, billboarding or academic detailing or health fairs, so to speak, just to gain more and more attention to this and identify individuals who would be interested in this avatar-driven platform. So once we identified individuals, we were able to contact them and go ahead and see if they were eligible through a consent and pre-screening process. Of course, the Institutional Review Board, this was a study from NIH. If any of you are familiar with the Easy for You tool, it's the Exercise Assessment Screening for You tool. This is a very simple set of items that is intended to assess patient safety or older adult safety for physical activity. It's supposed to be as inclusive as possible. Oftentimes we have challenges where older adults want to engage in physical activity, and unless they get permission from a clinician, they're unable to do so, and that's extremely important. But unfortunately, in doing that, they sometimes miss the start date of the workshop. They'll have to wait for the next one and therefore never really get some of the interventions they need. The Easy for You was created to still have some of these risks, still have risk assessment, understand a little bit more about and having communication with the healthcare team, but being as inclusive as possible that more people can engage, especially when the physical activity or the intervention is lower strain. It's not 100% physical activity. It's a lot of education. It's going at your own pace, etc. So if these individuals were eligible and able to participate, either a physical therapist or a trained coach would go to their home and onboard them, introduce them to the technology, show them what it was, collect some data, understand their home environments, and collect a series of baseline data. And in doing that, it's some self-reported risk data, some physical function testing, which I'll go over in a little more detail. We're curious, of course, about cognitive assessments because we know that physical activity and other types of risk factors Cognitive, especially, can cause falls. So we were very interested in cognition based on these educational and physical activities. Yep. And then with that said, also a little bit about the platform. We were still developing the platform, still assessing the platform, so naturally wanted to know more about how easy it was to use, how easy it was to learn. So the great news about this was a naturalistic approach. We let individuals engage with the technology as much or as little as they want. Some individuals were non-starters. Some individuals, like I said, did everything all at once and they wanted it all the time and everything in between. So we did this naturalistically and we collected data at baseline, but again, at 3 months, 6 months, 9 months, and 12 months. And we were able to follow individuals for an entire year. So our outcomes of interest, we really wanted to make sure that we diversified our outcomes so that we could identify as much benefit as possible. What is this platform truly doing? So with that, we started with self-reported risk assessments. I'm sure many of you are so familiar with the ABC, the activity specific balance scale, also the FRQ, which is the fall risk questionnaire, as well as the modified FFABQ. And so what we wanted to look at was self-reported risk of falling. We wanted to look at fear of falling. We wanted to look at avoidance behaviors. We also wanted to look at potential balance and confidence to be able to not fall and overcome falls if in fact they did occur. With physical function tests, we focused on the 30-second sit to stand test and the timed up and go. And so both of those are quite familiar, I'm sure, to most of you. And those were our physical functioning tests. The cognitive assessments, we wanted to make sure that we weren't overly burdening the data collection. So we wanted things that were certainly looking at a bit of the, organization, the executive function, processing speed, etc. So we honed in on the trail making tests, both A and B, where if you know about these tests, you progress in numbers and or numbers and letters, sequentially showing that you can maintain focus, but also accomplish this task in a timely manner with fewer mistakes. So that was the cognitive assessment. And then if anyone's familiar with the SUS, the system usability scale, this is how we wanted to understand a bit about the technology itself, whether it was learnable, whether it was usable, because we know for older adults, we certainly want things that are age friendly, things that can be used, things that will be used. And we don't want the design alone to be something that prohibits that. Fortunately, we got a wonderful sample. We were able to engage over 100 individuals in this trial. And with that, on average, these individuals are about 75 years old, ranging from 55 years old all the way up to 96 years old. Primarily, about 80% of these individuals were female, about 13% self-identified as Hispanic, 65% self-identified as white, 22% Black or African American, and 7% Asian or Pacific Islander. We saw that it was a relatively educated group, with 26% college educated, 45% having a graduate level education. So when we talk about the translation of this and the applicability in diverse settings, we need to think about the digital divide, education, affluence, who it is that's actually using this. About 1 in 3 individuals fell one or more times in the 6 months preceding the intervention. So that's on par, if not even higher than the national average. And what we're extremely encouraged by is that when left to their own devices, now again, these individuals had some potential self-selection bias. They volunteered to be a part of this study. But what we saw was that they participated in the study and engaged with the platform on average of 211 days. That's over 7 months. So out of a year, they were engaged mostly over 7 months, but you can see some individuals were in there for even over a year based on the time we actually got the 12-month data collection, but using the system a lot and a little, everything in between. You can see that about 36 a matter of balance classes were completed on average, ranging all the way up from 0 to 60 of these sessions, of these classes. And an average of 83 days were needed to complete what was assigned to them. And when you think about that, that's about 2 months, a bit over 2.5 months. And when you think about, for example, a matter of balance being an 8-week class, mostly that's about on par to get that kind of information. But yet people stayed in the study even longer, using the platform in different ways, still doing the exercises, even if they weren't doing the matter of balance classes anymore, just really engaging a lot with this platform. And you can see a picture of it here. Some of the most encouraging things are, of course, what did we learn? And we learned a lot. And that was some of the best part, is that when you see this table, just focus on those rows that have color. You can see the significant differences are shaded in colors. And you can see that the self-reported fall risk reduction. So again, that ABC scale, the FRQ, the modified FFABQ, those all significantly improved. So we saw that by engaging in these a matter of balance classes combined with the Otago exercises in this format of asynchronous, you know, avatar-led platform, that they perceive themselves to be at greater confidence to avoid falls, at less risk, less fearful of falling, less avoidant of certain situations and behaviors. In addition, in the green, you can see that there were significant improvements in the stand to sit test and significant reductions in the time to complete the timed up and go. So not only is it the subjective outcomes, it's also the more objective outcomes. They performed better over time on average. And in addition, which was very encouraging, in the blue, you can see that the trail making test A, so part A, significantly reduced, meaning that they were able to do so in a quicker time with fewer errors. That's actually really encouraging to see that these physical activities and this cognitive restructuring might actually have some benefits in this way. And then over time, and this is phenomenal as well, you can see in the gray that the learnability of the system continually increased over the course of a year. And that is extremely encouraging because there is the ageist bias that older adults don't know technology, don't use technology, won't use technology. That's not universally true. And we also saw that individuals were engaging with this technology, but also able to learn all of the various features and more of it to say that it's learnable and that it can be used and engaged with in the way that it was designed and intended. So extremely encouraging. And so that has, again, just wonderful implications, which I'll just talk about for 1 second. Naturally, what we're so encouraged about with things like this, generally speaking, is that in all of these pictures are real pictures from evidence-based programs out in our communities. And the thing is that the platform was effective in subjective, objective, cognition. I mean, there were some great outcomes here. And I think what it does is never replace the evidence-based programs that exist, but it's a nice complement. It can get into the hands of people who don't typically go to these programs and maybe don't necessarily want group-based settings. A lot of people aren't workshop people. That's not necessarily the way they wish to engage. So with that, we give options. And it's a way of having potential to reach those individuals who are maybe more homebound, again, don't necessarily want to go to certain locations, cannot travel to other locations. So this kind of expands that suite of services. Also, unlike other randomized trials, etc., we did a non-randomized pragmatic trial. We allowed this to happen naturalistically in real world context to see how much do they engage, what aspects do they engage with, and how well are they performing after. And this was very encouraging. We were able to see that there was a lot of engagement, a lot of success in their natural environments when not prompted or forced to do so in a controlled setting. And then, as I mentioned earlier, the potential cost savings for this are pretty profound when we think about in-person delivery, one-on-one delivery. We think about the cost and needs to be able to have a delivery infrastructure that can reach enough humans in our communities. We know that this can complement and alleviate some of those costs, and still get those outcomes from the programs we know and we love and we still support. So not a replacement, a complement. Now, I would be remiss if I didn't go over some brief considerations to be able to select some digital fall prevention solutions. These are not just in terms of education and the avatar type solution that I just described. This is generally for many, many different types of interventions, and there's so many products out there. The key is to be a wise consumer, to be able to ask for demonstrations, to be able to trial or test some of these solutions before you commit to them. And many of these organizations, many of these companies will allow you to do that. So I think that's a really important thing. The one thing that I always think is most important is that there needs to be evidence, and it needs to be well designed. So if you're thinking about a solution, has it been shown to work? Is it based on something that's more evidence informed? We know that because falls are multifaceted, the solutions need to be multifaceted. So are the are the technologies able to bring in different components like education, like physical activity, like home assessments, like communication or support? What is it that it's bringing in? Or is it just one thing where it allows somebody to notify if I were to fall? It's about matching the right solution to your purpose and making sure that it's based on that evidence. If it's a physical activity program, you definitely want it to be consistent, that people can engage it as much as possible for a long enough duration, but it also should be able to progress. The difficulty of these exercises should progress as a person gets more comfortable, more active, a little stronger. So we want to do so, but we want to do so safely. And so we definitely want that consistent engagement, something that's not one and done, something that's available for a lengthy enough time period that they can reap benefits. In addition to that, we think about accessibility. I talked about the digital divide earlier. So we want to make sure that the device that would be needed is accessible, that reliable internet access is available so that they can actually utilize some of these technologies or get access to tablets or smartphones or computers, maybe even go to a library situation to be able to get the intervention and be able to access it. Because if not, we're just leaving behind subgroups of people. When you see these technologies, you want to put your hands on them, you want to put your eyes on them, and you want to see, are they age friendly? Is the text of appropriate size? Is the navigation easy and intuitive? Because oftentimes they are not. And sometimes these technologies are not designed with older adults in mind, even though that's who they're attempting to sell them to. Paramount is, of course, safety. We always want to make sure that we have safety considerations. So we want to make sure that these technologies have some sort of initial assessment that will allow us to tailor the approaches, make sure that it's appropriate for them and their situation. But also we want to make sure that these technologies are able to observe or monitor the individual, that we're able to interact with them back and forth potentially, or at least there is some sort of data transfer or emergency response if needed. Safety is always important, and knowing this on the onset is extremely important to make sure that you're selecting something that will not cause harm and rather just benefit the older adult if it's used. In addition to that, of course, I'm very big into social connection and social engagement and also the motivation for continuing into something. So if there's an opportunity for gamification or a group dynamic, can people get together? Can we have like a leaderboard? Who's doing more this? Who's doing more that? A lot of times people are competitive. There's ways of just making sure that you want to come back to that platform or that technology. You want to engage. And oftentimes that's from an interaction with others, even if you're at home, or at least interaction with a leader, a facilitator, or some sort of administrator, some sort of feedback, something that can happen. And then cost, because if it's not about money, it's about money. Um, so those are some practical considerations when thinking about and selecting some of these. In the next minutes, very quickly, I would like to just switch gears a little bit to talk about this wonderful national initiative that's occurring now, funded by the Administration for Community Living, funded to the National Council on Aging. And of course, I'm fortunate enough to be on and have a lead role in the Research Advisory Collaborative for this. But really, what we're attempting to do is take these wonderful evidence-based programs that are already out there. And I already mentioned they're out there, they're reaching millions of people, but shouldn't they be reaching more? There are so many individuals who could benefit from fall prevention programming who don't have access. They're not offered in their local communities. They're not offered in potentially residential areas. There are certain individuals who historically do not access or do not have access to evidence-based programs, and there are certain organizations that don't really offer them. And maybe there's barriers to the structure of the evidence-based programs that prohibit that, or the cost, or the training infrastructure, or the licensing fees. And with that, what we're attempting to do is break down some of those barriers by trying to better understand a bit more about what it is that we can do to deconstruct programs, deconstruct interventions, deconstruct strategies into core elements so that we can identify what works well. So this ACL Innovation Hub, we're trying to conduct research, demonstrations, and evaluations to identify those essential elements to see if they work in traditionally underserved organizations and communities, to see if those elements, if offered, can actually have some benefits, like we know these evidence-based programs do, widening these collection of solutions that are available in our communities. So again, great group of people on this research advisory collaborative, um, just great things. So what we're attempting to do, we're doing a very different model here for research to try to understand those different components. Through a sophisticated process, we were able to identify the core elements or the essential elements that are effective to change outcomes for falls, and a slew of different types of outcomes. Again, self-reported, physical functioning, home safety, we're talking about cognition, social engagement, all of these different things that we know are so important. So we were able to break down all of these different studies, all these different programs, all these different initiatives, and identify the effectiveness in terms of the program components, like what did they include? Was it group-based, one-on-one? Who was the facilitator? All of those things. Who were the beneficiaries? Who was the older adult? What were they like? Did certain individuals benefit more than other individuals? What about the context? Where were they offered? How were they offered? How much was offered? What is it about the way it was done versus what was done, as well as the outcomes themselves? And so we identified all of these so that we could then break them down and say, there is a great menu of items that if you do some of these, the evidence says you will get some good outcomes. So let's test it out. And that gives a bit to increase the capacity of the aging network, to give flexibility to be able to offer many different things in different ways to our different and diverse older adult population. We can hopefully sustain them because cost will be less of an issue, training will be less of an issue, and of course, do so in a culturally competent manner. So as of right this moment, we just recently funded 18 demonstration grants across the country who have selected from the menu of items to identify different components that they're going to implement. They selected from the program components, the different types of beneficiaries, the different types of ways of doing these things, and they're now linking those to the outcomes. And so they're actively launching now, and they're getting guidance from us, the Research Advisory Council, and some of the implementers to be able to think about measure selection and the design of their intervention and how they're going to collect the information and use it to show effectiveness. So this is all happening. I just wanted to bring this to light because I think it's very exciting. We're trying to rethink the way that we're doing fall prevention. We're not abandoning in any way these evidence-based programs that have such a great history. We're just trying to better identify if there's more evidence-informed activities that we can complement, fill in gaps, find areas and populations that aren't getting these wonderful programs and give them something that can benefit them. So with that said, I'm going to conclude by saying, of course, we know that falls are complicated and technology potentially has a role in helping our older adults stay healthy, prevent falls. These technologies should be used in conjunction with these evidence-based programs that are already out there. They're not a replacement. I think I've said that multiple times now. And beyond that, we certainly know that the virtual translation, it's extremely important. It's something that we want everybody to see that these things are available. We can increase the impact by increasing the reach. Technologies can reach individuals who can't come to programs, can't come to workshops. And so we also know that they could be low cost. And when we select these technologies, we need to be informed consumers. We need to better think about what we're trying to accomplish, what the needs of our older adults are, and select wisely. Done and done. Thank you so much, and I greatly appreciate it.
Okay. Very nice, Matthew. Really appreciate it. Thoughts, comments, anyone? Okay. And do we have anybody in the chat? Okay. Sheila would ask, has asked, is it possible to get slides emailed to us on all of this information? Thank you.
And I hope everyone else would share their slides. And thank you so much for making this information available.
Okay. And Anne asked, the findings of this study started in the summer of 2025 would be excellent to know.
Yes. And each of these are an 18-month demonstration. They're not huge in numbers. They're much more about process and feasibility as well as outcomes. So hopefully in about a year and a half from now, we'll have some great things to share.
Okay. Okay. Well, hopefully you'll return as a speaker, sir, and share your experiences with us.